Good evening. On behalf of the Student Academy of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar, Third-Party Payers and Third-Party Administrators. My name is Andrew Abernathy, and I am pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. If you have any technical challenges during the session, please use the chat feature to make me aware, and I will be glad to assist you. Please type your questions into the question queue, and they will be addressed by the presenter at the end of the presentation. Today's presentation is being recorded and will be available for online viewing next week. At this time, it is my pleasure to introduce the course moderator for the session, Kaylee Babbage, SATA Board Advocacy Chair and recent audiology graduate from Rush University.
Thank you, Andrew. On behalf of the SATA board, I am excited for the opportunity to welcome AUD students from programs across the country to this session on third-party payers and administrators. It is also my distinct pleasure to introduce today's course leader, Dr. Alicia Spohr. Dr. Alicia Spohr, AUD, is the audiologist and owner of Designer Audiology. She earned her Bachelor of Arts degree from Michigan State University. After completing internship rotations at Bethesda National Naval Medical Center, Fort Belvoir, and Kendall Demonstration Elementary School, Dr. Spohr completed her fourth-year externship at the Mayo Clinic, Arizona, and she earned her Doctor of Audiology degree from Gallaudet University in Washington, D.C. After graduation, Dr. Spohr joined the hearing aid and cochlear implant teams at Mayo Clinic, Arizona, before moving back to Maryland. She worked at 2 Maryland-based private practices before opening her own business. Dr. Spohr is the current legislative chair for the Maryland Academy of Audiology and past president of the Academy of Doctors of Audiology. I will now hand things over to Dr. Spohr to begin her presentation.
Well, thank you very much, Dr. Babbage. I appreciate it. And Mr. Abernathy, thank you so much for being with me tonight. And for all of those who tune in later on, welcome. I'm glad, as we were chatting before, you can always watch this on 1.5 and double speed so that maybe some of my former students don't have to listen to me yammer on as much. As Mr. Abernathy mentioned, I am more than happy to take questions for any of those who are live. So please feel free to put them in the chat box and we will go over them at the end of the session, and I can stay on as long as needed. I also do have my email address listed at the end, so you can always contact me if you happen to be watching this recorded or at some other point in time. So with that being said, let's jump in. For those of you who don't know who I am, my name is Alicia Spohr. I am an audiologist, and as you heard, I'm the current legislative chair. You can see a couple things that I do in my free time when I'm not doing business-related and practice-related things. I mainly do audiology. This is what I looked like pre-COVID-19 pandemic. But just before my webinar started, my husband looked at me and said, "Oh, this must not be a live webinar." So you can imagine what I look like currently with my pajamas on and my hair pulled up. So that paints a picture for you, and hopefully you're in as comfortable of clothes watching this as well. So just wanted to go over a couple things. I know that you guys have had some amazing presentations already, and you have some to go. And me included, in a couple of weeks that SATA has put together for you. So I want to make sure that we're not getting hung up in things that have already been touched upon, although you will hear a little bit of overlap between what has already been mentioned and some of my points today. And that just goes to show you how billing, coding, reimbursement, insurance credentialing, contracting, and administrators are all kind of related. And my guess is that next week when Dr. Consalia comes on, you're also going to hear a little bit of overlap when he talks about buying groups and management companies as well. So I know Dr. Cavett in her recorded presentation talked a little bit about Medicare Part B. And I know Dr. Abel touched on Medicare Part C or Medicare Advantage last week, workers' compensation, and insurance contracting. So I have some really big shoes to fill with those people. So today we want to kind of round out the mix when it comes to insurance and really talk about third-party payers. And so with that, let's go ahead and dive right in. So third-party payers, as defined here, are plans that are funded, subsidized, and offered by an employer, state, or federal entity, or purchased by an individual, all for a monthly fee. So health insurance, as we often refer to it, is really an option for an employee that is offered by the employer. So the employee, the person who's working at a company, does not get to pick what their health insurance is. They may get to pick from different plans, but they don't get to say, well, I want glasses and hearing aids and a high deductible, but no copay and a $3,000 out-of-pocket maximum. That doesn't happen. The employer puts a package together, and then if there are multiple packages, the employee gets to choose from that package. And so obviously, whichever package that employee chooses, they're going to pay a fee for it and then be able to utilize that system. So the different plans are going to have different deductibles, different coverage, different rates. And I know, again, Dr. Abel went over some of those definitions and descriptions last week. So I would highly recommend you look at that if you have any questions. I really want to point out that within the profession of audiology, at least at this point in time, beyond Medicare, everything is optional for audiologists. So when we talk about third parties, audiologists have the option of either joining or not joining, participating or not participating in all of these options except for Medicare. So right now you are a mandatory Medicare provider, which means you should all be enrolled and offering service to those Medicare beneficiaries, but everything else you have the option of choosing. Now, I realize some of you may be employees at a practice, so maybe you don't get to choose if you are working with Cigna or Aetna or United Healthcare. But if you are a decision maker or if you are a practice owner, then you do get to make those decisions. So with that decision comes a lot of responsibility. So you can decide who you want to contract and do business with. And if you don't make a decision, somebody may make that decision for you, or you might make the decision not to do anything, which is fine too. But my big thing, especially nowadays, which Dr. Cavett says a lot, is you need to make an informed decision. Whatever you decide may not be the right decision for everybody else, and everybody should have that right to decide for themselves. And again, you shouldn't be made to feel badly if you make one decision based on your practice, but somebody else doesn't agree with it. But at the same time, and this is my personal opinion, don't complain about it. So especially when we talk about TPAs later on in the presentation, there's a lot of complaining that goes on, and it's really unnecessary. If you don't like something, then you need to change it. And so you can do that as an employee, kind of working through the data and working with people who make those administrative decisions, or you can do that as the actual decision maker and moving through whatever you need to do to make changes to those third-party payers. So again, I know that Dr. Abel explained this in her presentation, but I just wanted to touch on it. There are really four main types, and really three main types of payers: the HMOs, the PPOs, the POS, and the ACOs. And the only reason why I point this out is because we're going to look at an insurance card in a little bit, and so you're going to see where one of these things would be denoted on that type of insurance card. This is not the insurance card that I was just referring to, so I apologize if I just referenced that, and am going to make you be in suspense for another couple minutes. But the most common third-party payers are Medicare and Medicaid. And so Medicare covers approximately 44 million Americans, which is about 15% of the population. And Medicaid is going to cover 75 million Americans, which is about 25% of our population. So between those two programs in and of itself, we're looking at 40% of the coverage within the United States. Now, there's a big difference between Medicare and Medicaid. They are both third-party payers, and as I mentioned earlier, audiologists are mandatory providers for Medicare. Medicare is a federal-based insurance program. We all know that we pay taxes to Medicare, and I'm older than probably the majority of you listening to this, so we're all hoping that maybe Medicare is still there because you're paying into it at this point in your lifetime. Medicaid, in general, used to be for children or those individuals who may have been on handicap or disability. It has expanded more and more into the adult population, especially with coverage of hearing and hearing aids in the most recent years. However, Medicaid is entirely optional. There is no mandatory coverage for Medicaid when you're an audiologist, and it varies based on state. So a Medicaid program is going to be state-run. A Medicare program is going to be federal. And the way that I always thought about this, they were a little confusing to me, especially when I was a student trying to figure this out. When I would write the two words, Medicare, Medicaid, the longer word, the older the people had to be. So the longer the name, the older people fell into that category. And that's kind of how I thought about it. Medicare is traditionally going to be your over 65s. And again, Medicaid is typically more often the kids at the state level. So when it comes to third-party payers, everybody should understand, and maybe I should preface this, everybody should understand a private pay is kind of that first-party payer. Whoever the patient is, they're paying privately, that's the first-party payer. Then you've got third-party payers. Again, you're going to be a provider of Medicare. I don't know if I've said that enough times yet, but these are the most common third-party payers. And these are things that companies that I'm just thinking of off the top of my head. There are probably hundreds or thousands of them if you get into the nitty-gritty based on the plan. So I'm sure if you're watching this, you might think, oh, Alicia, there's this one, or oh, Dr. Spoor missed that one, because some of them are regional and some of them are bigger. So when we refer to the Blues, that Blue Cross Blue Shield or BCBS here, they have so many different options through Anthem, through Blue Choice, through Healthy Blue, through Blue Cross Blue Shield. They're just huge, but they are a third-party payer. And so again, you're going to see a lot of them here that you might recognize. Probably the biggest ones are Aetna, Blue Cross Blue Shield, Cigna, United Healthcare, and then Kaiser always jumps in there, although Kaiser is a little different because it's a closed system. But again, these are going to be your most common third-party payers. So what do we mean when we're talking about networks of third-party payers? So again, I know Dr. Abel covered some of this in her talk last week, but when you are an in-network provider, it means that you've gone through the credentialing program with a third-party payer and you've signed a contract with them. And it's so important that you read that contract to make sure you're agreeing to what that payer requires you to do. When you become an in-network provider, the insurance is going to advertise your participation with that network. So when I go on to my Blue Cross Blue Shield portal as a member of Blue Cross Blue Shield, and I say I need an audiologist in the state of Maryland, where I'm located, it's going to show me the audiologists in the state of Maryland. And it's going to show me everybody who is in network. And so Blue Cross Blue Shield is going to quote unquote advertise that I am in network with them. So those members are going to be funneled to your practice because you have agreed to participate with them. You're also going to accept assignment for any covered services at the rate that's set by the insurance. So this is where the fee schedule comes into play. Every year you should be getting a fee schedule from any of the payers that you contract with. And it's going to tell you for every CPT code what that plan is going to pay you when you actually provide that service. So for example, if you're doing 92557, which is a comprehensive audiologic evaluation, and you are in network with the United Healthcare, they may pay you, and I'm making the number completely off the top of my head, $42.13 every time you do a 92557. So when you see those patients and you are in network, you are going to have a reimbursement rate from United Healthcare, $42.13. And when you are in network, you agree to accept that payment as payment in full. So that's why it's so important to read contracts and look at your fee schedule, because if you need $300 to do a 92557 and this insurance is only going to pay you $42, maybe it is not a good insurance for you to be a part of. And we're going to talk about how you pick and choose which insurances you want to be a part of in the next slide. Additionally, because you are in network, the individual who comes to see you knows that there's going to be a copay, a coinsurance, or a deductible at the time of visit. So there's typically going to be some out-of-pocket cost incurred that they are going to pay you directly, and they know that that is the portion of their responsibility. So if you are familiar with Medicare, Medicare is an 80-20 system. Medicare covers 80%. And the individual pays 20%. Think of the copay, coinsurance, or deductible as that 20%. The in-network company, the insurance company, is going to pay approximately 80% or whatever that number is. And then the copay, coinsurance, or deductible is going to be what the individual has to cover, kind of like the 20% with Medicare. It doesn't always work out to 80-20, but that's kind of a good way of thinking about it to kind of get all your ducks in a row to remember that. So again, when you are in network, you're accepting assignment, which means you are not going to balance bill the patient for any of those covered services. When you are an out-of-network provider, it means that you have no contract with these third-party payers. So if you decide to not work with Cigna and somebody comes in who has Cigna insurance, you have no contractual obligation to that insurance company or to that patient that's in front of you, which means that you've never signed a contract with them or you have terminated your contract with them, and that the patient is going to pay the usual and customary charges to you as the provider at the time of the appointment. So again, going back to the example, if you charge $300 for a 92557 and you are out of network with whatever insurance that patient has, that patient is going to be responsible to pay you $300 for that hearing test. Because you are out of network, the insurance is not going to funnel any patients to you, and they're not going to list you anywhere on their system. So they are not going to promote you because you are not providing any benefit to their actual members. Whereas if you're in network, they are. So when it comes to out of network, you have to be very clear to any of those patients that you are out of network and they're responsible for usual and customary charges at the time that they come in, and you should be telling them approximately how much that costs. Now, I should mention, when patients come and they pay you and you are out of network, so going back to my example of Cigna, patient comes in with Cigna, you charge them $300 for a hearing test. That is a made-up number as well. And the patient says, well, I have out-of-network benefits. That's great. You can do a couple things. You can give the super bill information to the patient with your diagnosis codes, the CPTs, and any modifiers, and say, here's your paperwork. Have a great time. You have to submit this yourself. Or what is maybe more common, I don't know that for sure, sometimes as a provider, you may bill that person's insurance as a courtesy to them and make it very clear that they have already paid you as the provider a usual and customary charge, and that any reimbursement is going to go back to the patient. But if the insurance only reimburses 10% or only reimburses a set dollar amount for an out-of-network coverage, that does not mean that you as the provider have to accept that as full payment. You have no contract, so you are getting paid your usual and customary, and the patient is more likely going to pay you more than what they would have paid if you had been in network. Hopefully that makes sense. I know that a lot of the EHR systems you can bill as a courtesy pretty quickly and easily, and I have found, at least with my patients, that that makes a big difference, just because they don't have to deal with that paperwork. Doesn't mean the insurance is going to pay them any better for out of network. It just means that those patients don't have to go through the headache of trying to submit the paperwork themselves. So the big question is, how do you know what insurances you want to be in versus out of network? The first way you want to figure this out is you need to do a market analysis. And so you, as the provider, the business owner, the decision maker, the department head, whatever it might be, you need to actually look at your geographical area, and you need to figure out how many current providers, how many current audiologists are in your geographical area, and where are they located. So again, I'm in the state of Maryland. We have what we call the triangle. It's Baltimore, Washington to Annapolis. It makes a little triangle shape. And when you are in that area, sometimes 3 miles can be 20 minutes because of traffic. And so most patients in our region are not going to travel more than 20 minutes when they're going to some type of provider location. Now, I grew up in Michigan, if you're in Michigan and you will only travel 20 minutes, that very well, especially if you're speeding on the east side of the state, could be 30 miles. So you need to know what patients are normally traveling, how far they're willing to travel, and then how many providers are located there. And those providers need to be in or out of network. So if there's already 300 audiologists in the Triangle region with one of the third-party payers, that third party may not want to admit you into their system, or you may not want to be a part of it because there's already so many other audiologists that the chance that you might get a new patient when they're already going somewhere else because they have established care could be quite low. Again, how long do those patients have to travel? And more importantly, how long is the wait time to see those providers? So if you offer some type of services that aren't being offered, or if those other providers, let's say there's 10 of them in your area, but they all have a 3-week waiting list, that's not something to brag about. As Dr. Gans always says, you want to get patients in as quickly as possible. So if you have that long, or if your area has a really long waiting list, then maybe you go in and say, you know what, I can get people in within a week. Great, that's something that you can do that other places can't, and that might be a reason that you want to be in network. The other thing, or not the other thing, but one of the other things you also want to look at is, what do the employers in your area offer for their third-party payers? So if you are in the headquartered state where Home Depot is, and Home Depot offers Humana insurance, and you want to get those patients that work for Home Depot, then you better take Humana insurance, because that's what the majority of those people are going to have when that employer offers that insurance. So it's important to know some of these things, and sometimes you can figure it out. Sometimes you might have to call and do a little detective work. Sometimes you might just know when you've been in that geographical region what is offered. And it could be multiple plans, it could be one plan. So that's going to be important as well. And then you need to know how many individuals are covered from those insurances. So for example, if Home Depot offers 3 different plans, but everybody chooses Humana and nobody chooses GEHA, then maybe that's the way you go, being in network with Humana. So again, you have to look at those offerings. What are your referral sources? So when you are looking at the local region and you're looking at your family practice, your internal medicine, your geriatricians, your cardiologists, your dermatologists, your pediatricians, whatever referral source you are going to have, you need to know what insurances they have. Because often what happens is when you sign a contract to be in network, and this is true mainly throughout medicine, when you sign a contract, you often sign something saying that you will refer only to providers who are in network, which means that if you're a primary care doctor who's referring you everybody who has Cigna, but you're not in network with Cigna, and that insurance company finds out, that provider might start sending everybody to an audiologist who does accept Cigna. So if you have some really strong referral sources, you definitely want to make sure that you're all on the same page, offering those same types of insurance plans. The same is true with your local hospitals. Now, hospitals are often going to take a lot of different insurances, and I'm not necessarily saying you should take all those different insurances, but if your hospital does see a lot of patients who have Medicaid, which is that state-run program, and you want to see those kiddos, and now more often those adults that are coming through on Medicaid, then it might be advantageous for you to be in network with Medicaid. Some of the benefits that come with looking at different insurances is the hearing aid offerings. So I know of two very common third-party insurance payers that have very lucrative hearing aid benefits. And one of them is up to $5,000, and the other one is $2,500 every so many years. And so you may look at those patients and say, well, even though there's not a lot of them, when those patients come in, not only is diagnostics covered, but they also have this great hearing aid benefit. And if you are in network, then you may get more patients coming to you because you take their insurance when they actually do need some type of amplification option. And then affordability. If you don't know your hourly rate, and I'm not sure, I didn't listen to everybody's presentation within the last week, but if you don't know your hourly rate, I will walk you through that in a couple of weeks when we talk about unbundling. Everybody has an hourly rate. I don't care if you are a student, and one of my former students, if she's listening, will hopefully smile with me. She's very cheap. I think she had an hourly rate of like $7 or something when we figured it out in class. And then there are people who are very expensive. So if you don't know what your hourly rate is, if you don't know what your practice's hourly rate or your department's hourly rate is, you have no data to make these decisions. So that's first and foremost. And again, if you don't know how to do that, there are lots of great webinars. You can probably Google it and figure it out, especially if you have or are working on a doctorate degree. Or if you tune in for 2 weeks, I'll put in my shameless plug that I will also help walk you through that. You also need to look at what is the covered amount that is being offered through these insurance and third-party payers, and that's that fee schedule. And then you sit down and make the decision. Can you even afford to participate? If that insurance does not bring you enough patients to cover your hourly rate at however long it takes you to see those patients, to run that practice, to run that department, then you're going to put yourself out of business. And so that's why so many people, if you read through some of the Facebook pages and such, will start complaining, and it's like, they're putting me out of business. You know, the thought is, well, you join them, right? You can leave them, which we'll talk about in just a minute too. But if you don't know what your hourly rate is, again, you have no data to stand on. I am a math and science person. So when it comes to in and out of network, there's really no correct or incorrect answer. It's all a business model, and I can't stress that enough. So many people get emotional over, well, I would never accept that. I would never see those patients. I would never do this. That's all emotional. There is always a correct answer based on data. And I hope that you will start to look at it through some of that data-driven information if you feel like it's a little emotional, because once you start looking at it on the data side, it can be very enlightening as to what you do and don't participate with when you can make those decisions. And that's true with, again, third-party payers, except for Medicare. You are going to be in network with Medicare, and that's true with third-party administrators. I know of quite a few practices that are doing phenomenally well. I mean, phenomenally well, and they are only participating with Medicare because they have to be. It's not even because they want to be, it's because they have to be. So everybody else is paying them privately because they're out of network, and they are killing it. And then I know a lot of practices that their philosophy is take every single insurance because we want the patients to come in, and we don't want those patients to have to think about whether or not they're going to have coverage when they come in to see us. And they are also doing phenomenally well, but you have to have very different structures and very different businesses and practices being run in different ways in order to do those two things. So it is doable in both ways and with everything in between. But again, you have to make that decision based on the data. And then the other thing too is you really have to constantly reevaluate your options. So what is good for you in 2020 is probably not going to be what's best for you in 2023 or 2025. And so who knows how long these webinars are recorded. Maybe, you know, my grandkids will be listening to it and thinking how crazy it sounds for me to talk about 2020. But that being said, this is an ever-changing models and ever-changing system, and those fee schedules are going to be changing every year. Your practice is going to be changing every single year, and so you constantly have to be looking at this. And so most people, when you talk to the business owners that are very savvy, which a lot of them that have come before me are extremely intelligent, and I hope you're taking all you can from them, but they're going to sit down and look at all these numbers and information at least once a year. And it may not be big changes once a year, but once a year over the course of 3 years, that's when you might notice a big change. So a couple helpful hints that I've learned as I tried to navigate this on my own over the past few years, leaving a medical center that kind of did everything for me, and then learning it in private practices and then doing it on my own, is that the network status that the insurance talks about, which we said, if you are in network, those insurances are often going to advertise for you. They're not always up to date. And so I've had multiple patients call me at my current practice and say, oh, I see that you take my insurance. I say, we probably do. What insurance do you have? And they tell me, and I say, no, I'm very sorry. We do not currently participate with that insurance. We are out of network, and I explain that to them. They say, no, I looked at my insurance website and they have you listed. So you really need to know, especially if you are an employee or if you're hopefully the one making decisions, you know if you've signed a contract, but you need to really be up to date on that, because you're going to get patients or prospective patients that call and say, no, you're on the list, and say, no, I'm really sorry, I shouldn't be. Your insurance just hasn't updated that. And it doesn't matter how hard you try, somebody's always going to be wrong somewhere. And that's why I think Dr. Abel was so great when she talked to you last week about keeping your CAQH or your CAC up to date, because that will help kind of weed some of those things out. Again, if you're going to be a network, it does require a signed contract. There are absolutely no benefits, no in-network coverage until that contract is fully executed. And fully executed means you as the practice has signed it, and the insurance company designation or designee has also signed it. So until you have a signature from both sides, there's going to be no coverage for that patient. So those might be patients you keep a wait list and you call them as soon as that contract is fully executed, or those might be patients that you have to schedule out a couple weeks, a couple months, gosh forbid. If you do things correctly, it can be very fast. If you go through a lot of negotiating, it can be very long. So I know when I was doing contracting, it took me less than 3 weeks to get my Medicare contracting entirely done from start to finish. It took me more than 9 months to get my other third-party payer system. And there's another third-party payer that I've been working with for 4 years now, and it's still not done. So you have to be religious, but you also have to understand until it's signed, there's no benefits to those patients. When you are relocating, and this is something that I think a lot of people don't understand, especially when I talk to them at different conferences or boot camps that I sit in, insurances, when you are in network, an in-network provider is based both on that provider, you as the audiologist, and the practice that you are located at or working within. So when you become an in-network provider, you have to provide information on both the practice and on the provider. If you as a provider leave and decide to go to either a different practice or decide to open that practice on your own, your insurance does not follow you. So just because you were a practitioner that was in Geico, right? Geico, does not mean that when you leave and you open your own place next year that you will automatically be an in-network provider for Geico again. It means that you have to go through the entire process over again. And that third-party payer, in this example, Geico, could say, no, we don't want to contract with you. We already have enough. And even though you were an in-network provider before, does not mean that you're going to be allowed back in again. So just know that when you relocate, things do not follow you. And that being said, when you leave a position, it is not uncommon for the insurances to have absolutely no idea that you've moved or you've opened a different location or you don't work in state A, you now work in state B. And at a certain point, I'm not 100% sure they always care, but when you don't keep those insurances up to date, then the insurance might think that there are a lot more providers in a geographical area or in their network when there are really not. So if it's possible, and just before you leave or just before you change positions, if you can inform the insurance of that, it can be very beneficial for you and for other providers who might want to become in-network later on. The reason why I mentioned you might have to do it just before you leave is because you often have to send in the information based on, or you have to send in the information on the company's letterhead. So if you've already left the company and you're trying to go back and fix it, it may not actually take. So as I think Albert Einstein said, right, the only constant is change. Your insurances are going to change time to time. Nothing is permanent, and that's perfectly fine. You need providers. The insurances need providers so that individuals will subscribe with that insurance. If you were to sign up with United Healthcare and United Healthcare had no dermatologists in the entire state of Colorado, and you were in the state of Colorado, would you sign up with United Healthcare? Maybe, maybe not. But if dermatology is important to you and that's what you're making a decision on, then that insurance isn't going to be able to promote that they are best for those individuals. So the insurances need the providers just as much as sometimes the providers need the insurances. So know that it is a two-way street. A lot of times insurances are not going to negotiate a lot of things with you, but if there are no other providers or you are in a geographical area where there's just not a lot of providers no matter what, you actually have a leg up, and that can be really helpful when you're talking about in-network. At the exact same time, you can leave almost any insurance, again, except for Medicare right now, at any time. So typically when you sign a contract, you do have a set amount of time that you do have to be there. So it's typically 1 year. When you initially sign, you have to be a member for 1 year. And then there's some sort of clause about what to do if you want to leave. And so sometimes that's in writing, sometimes that's through email, it's through fax, whatever it might be. And then there's an amount of time. You have to give 30 days, 60 days, 90 days, 120, 180, whatever it might be. So just know that if it ends up being absolutely awful and terrible experience, you just walk away. Again, you might have to wait a few days, months, right, 1 year before you can walk away, but nothing's ever permanent. So know that you can add and change and leave at any time. It's just a little bit of work to do that. So when you are in network, a couple things that you as a provider want to do. Prior to a patient coming in for an appointment, you want to get their insurance information when you schedule their appointment. And it's very easy to do. Everybody is being asked for their insurance when they schedule an appointment, so don't think that audiology is unique. And if a patient doesn't have it, just tell them to call you back when they do, and you'll finish scheduling. There's no point in going through the process with the patient if they don't know what their insurance is. Partially because you want to verify those benefits just prior to the patient coming in for that appointment. And the reason why I say that is because a patient is going to be eligible for insurance on a very specific date. And so a lot of times it's calendar years. Sometimes it's July 1 through June 31st. Sometimes it's October 1 through September 30th. All that's based on the employer and when that benefit year starts. But you want to make sure that when the patient walks into your office that you have the up-to-date information about what coverage that patient has. So a lot of times people are going to be verifying benefits maybe 1 or 2 days before the patient comes in. And this is why it's so important to get that patient information. So you need their name, you need their date of birth. Sometimes you need their address, you need their insurance or their subscriber number, the group number, and then there's typically a provider phone number often on the back of the card if you need to call and check the benefits. And sometimes when you're in network, there's a portal that you can get a lot of information on. Sometimes even if you're out of network, you can use the portal and get information. And then you want to get the subscriber's information as well. So for example, if you're working with a 1-year-old, that 1-year-old is not going to be the subscriber because that person is 1 year old. But if mom or dad is the subscriber, you want to make sure you have mom and dad's name, their date of birth, make sure the address is the same, which is not always true. Don't ever presume the last name is the same, and go from there. The other thing is that you want to make sure that you inform the patients of any costs that are going to be due. So you might have a blanket statement, or your front desk might have a blanket statement that says, co-pays and co-insurance deductibles are due at the time of the appointment. Hopefully most people know that, but it's never a bad idea. But it also might be one of those things that if they're coming in for vestibular testing and you're using video goggles rather than electrodes, partially because I think it's the 21st century, well, those goggles may not be a covered service. And so you might want to inform those patients, just so you're aware, you're going to have an X dollar out-of-pocket cost for this non-covered service. It lets us better evaluate your vestibular system, but it's a non-covered service. Nobody likes surprises. They don't want to come in and find out, oh, they have an extra $1,000 they have to pay. So any information you can give them ahead of time is going to be extremely helpful. At the time of the appointment, the patient's going to come in and they're going to pay that copay, coinsurance, deductibles, and any non-covered costs. So again, hopefully you figured out all these non-covered costs, or you can give a patient an estimate. For example, we're going to do your hearing test. You mentioned you had difficulty in background noise. I'd really like to do the speech and noise test. This is why it's beneficial. This is what it will tell me, but it's a non-covered service and it costs X amount of dollars. The patient could say great, or the patient could say no way. You have to make that, or you have to understand that it's the patient's decision. But at that point in time, they can decide whether they want to do that or not. And then if so, then they pay for that cost. And then any paperwork that might be required, and I'll show you the paperwork in just a minute. After the appointment, you're going to submit the claim for each date of service, which means if the patient came in on Monday, you submit a claim for Monday. If they came back on Wednesday, you submit a claim for Wednesday. And then on Thursday, you submit the claim for Thursday. So each appointment is going to have a claim that's being submitted. And after the insurance processes it, whether you're in or out of network, you're going to get an explanation of benefits. And so almost all the time, whether you are in network or out of network, you get an explanation of benefits. You will always get it if you're in network. If you're out of network, I find that you get it about 95% of the time. And that's what's going to detail the explanation about what was covered, what was not, how much is going to be paid to you, how much the patient should have already paid at the time of the appointment, and then any other benefits, paperwork, whatever might need to be there. So at that point, you're going to adjust the invoice, and then you're either going to bill, which hopefully you don't need to, or refund the patient. Hopefully, again, once you get good at it, you don't need to do that either as necessary. And I know Dr. Abel covered how to read an EOB, so I highly, again, recommend going back to that if you don't know how to do that. So I mentioned on the last slide, there are some resources that can be helpful. You can find them at ADA's forms and library, the financial policy and the notice of non-coverage page. And then Medicare has their advanced beneficiary notice. So if you are working with a patient who has that third-party payer of Medicare, you're going to be using that ABN. So one thing I want to make sure everybody understands is the difference between a secondary payer and a supplemental payer. So these are both third-party payers, and I know it sounds weird because we've got a first-party payer, which is going to be private pay. We've got third-party payers, which are going to be your insurances, and now we've got the secondary and tertiary and everything like that. But I want to make sure this is something you understand because, again, I think it's very important, kind of like Medicare and Medicaid, secondary supplemental as well. A secondary insurance is going to be billed second in the insurance line. And I know you think that sounds crazy, but primary insurance is always going to be the first insurance bill. That's what everybody has who has insurance. They have a primary insurance. If there's a second insurance, then they have a secondary insurance. And so what happens is the primary insurance pays, and then the claim gets sent to the second insurance, and then they pay whatever could be covered. The important thing to note is that when you have a secondary insurance, it has its own set of coverage guidelines. So if your primary payer covers a CDP test, your secondary insurance may cover CDP or it may not. If your primary payer covers or does not cover hearing aids, your secondary payer may or may not cover hearing aids. They are two separate entities that both have their own sets of coverage. It's just that the primary gets billed first and then the secondary gets billed second. And that has to be denoted when you're setting up those insurances. So again, a secondary insurance, it does not matter what the primary insurance covers. That secondary insurance is going to make its decision based on what that coverage contract says. Hopefully that makes sense. A supplemental insurance, again, is going to be secondary. So there's always going to be a primary when you have a supplemental insurance, but that primary is going to pay first, and then the supplemental insurance is going to pay second. The difference is that the supplemental insurance is only going to cover what the primary insurance covers. So if the primary insurance covers BPPV testing, the supplemental insurance is going to cover BPPV testing. If the primary insurance does not cover speech and noise testing, the supplemental insurance is not going to cover speech and noise testing. So supplemental means that it's only going to cover what the primary covers. Most of the time, and I think all of the time, but right, prove me wrong, I think all of the time you are going to see supplemental insurance with Medicare. So a patient has Medicare, and then we all see the commercials for AARP as a supplemental insurance. That is supplemental. That insurance will cover what Medicare doesn't. So Medicare pays 80%. 20% goes to the supplemental. That supplemental insurance pays 20%. Medicare does not cover hearing aids or anything around it. Send it to the supplemental. Supplemental is not going to cover hearing aids or anything around it. Going back to a secondary, if you have Medicare as your primary, Medicare does not cover hearing aids or anything around it. Send it to the secondary very well could have coverage for hearing aids and the services around it, or it may not. It's entirely independent. Again, hopefully that makes sense. Those are two things that I see very commonly mixed up, and I want to make sure that you all understand it. The other thing that I think is super important, and this is why I talk so long, is that I want to make sure you all know how to read your insurance card. So most of you probably have a third-party payer. You're probably not private paying for all of your medical. You could be, but I doubt that you are. And I know this picture is just a little bit fuzzy. It's not your eyes. It is just a little bit fuzzy, but it's like the fourth one I came up with. So let's look at this specifically first. Here is your third-party payer, which we often call an insurance company. So in this example, it's Blue Cross Blue Shield of geography, because they might put in of Alabama, of California, of Idaho, whatever it might be. That is your third-party payer. Here is your subscriber's name. This may or may not be your patient. So the subscriber is the person who actually works at the company that is offering this Blue Cross Blue Shield plan. So in my household, my partner is the one that works for the government, and the government offers Blue Cross Blue Shield. And so my partner is the subscriber. He is the member. The dependents are anybody who fall under that subscriber's insurance. So this could be a spouse, a partner, children, probably not animals, although I love my dog oftentimes more than a lot of other people. But this is where your dependents are going to be. So at some point, the insurance cards need to have that patient's name listed on there. So the patient might be the member, the patient might be a dependent. It doesn't matter, but their name needs to be listed on there. Otherwise, they likely won't have any benefits. Here is the member number, which is sometimes called an ID number or a subscriber number. Oftentimes there are letters mixed in with the numbers. So it's very important, especially when somebody's getting information over the phone, to ask if it's a 0 or the letter O. And if you're not sure, you might actually have to try to figure it out yourself. But it is sometimes difficult to separate those zeros and those O's. Might be very difficult for older patients to separate a 1 and an I or an L, but that ID number is how the insurance knows who the person is. You may or may not have a group number on an insurance card as well. If you don't have it, don't worry about it. If you do have it, make sure you get it. Those groups will often tend to tell you what plans are being administered. So again, I mentioned federal government, where my partner is, and the group numbers delineate some of the different benefits we have right off the bat based on that group number. So it can help you get more detailed information, and the more you look at insurance cards, the easier it is. Here's the effective date, and this is the date of eligibility. So sometimes, especially at the end of benefit years, the insurance companies will send out new insurance cards, and so a person may get a card before they are actually eligible for that insurance. So if this effective date said July 1, 2020, and it's currently June 2, 2020, that person is not eligible for their benefit yet. And so that's a really important thing to note, because if you start providing services and that patient's not eligible, then they are responsible for your usual and customary charge. That's a big surprise. Nobody likes surprises. Here's where you can tell what co-pays or co-insurance or even deductibles might be. So on this plan, an office visit is $15. Now, how do you know if you're an office visit or if you're a specialist? Audiology is a specialty care, and office visit is going to be primary. So your primary physician is going to be $15 with this plan, and the specialist is also going to be $15. They're not always going to be the same. They might differ by a couple dollars. They might differ substantially. But as audiology, we are charging that specialist copay. You can see there is a $50 deductible. So if the patient was coming to see you for the very first time on January 2nd of a calendar year benefit, they're going to have a $50 deductible and a $15 specialist copay. And when you get and verify benefits either through a portal or through an online system, they're going to tell you how much the patient has paid towards a deductible and how much they have remaining. So you need to collect whatever that might be at that time of service so that you don't have to chase the patient down. This is where the HMO, PPO, and POS really came into play, because on this card, which sometimes it will tell you, sometimes it won't, this card specifically says this is a PPO. And so what that means is that preferred provider organization, the patient can go anywhere they want. They're just going to pay a little bit more if they go to somebody that is not a preferred provider. So they're going to have out-of-network benefits, but not nearly as little cost as they were if they were an HMO system and in-network. So let's look at a different card just to kind of point this out to you. So again, this kind of came pre-labeled, which was even nicer of United Healthcare. You can see bubble number 1 is your insurance payer. That's your third-party payer. This is a United Healthcare card. Number 2 is your subscriber or your patient name. So this is a test customer. It's a card I just found online. So right long first, me, C, last name happens to be the member at this point. The reason I like this card is number 3 shows you a payer ID, and that's a 5-digit code, and that's how when you bill an insurance through your EHR, the EHR doesn't look up United Healthcare and try to figure it out. It's actually going to look at a series of numbers to figure out where the insurance claim gets sent. And so that payer code 87726 in this example tells your health records, your EHR, to send it to United Healthcare. Number 4 looks at your co-pays and co-insurance. And so again, this is a nice example because The copay, it's a $25 office copay. It's a $100 ER copay. It's a $50 specialist copay. But then you've got co-insurances. It's a 15% urgent care and a 15% co-insurance, and then you've got your deductible, $2,000 individual and $5,000 family. So if you're not quite sure what you need to be charging, this is when you look at your contract, you verify your benefits, but this is going to give you a snapshot, which again, the patient is literally holding on to, and so you can point out to them, no, look, you have a $50 specialist copay every time you come to see me. Number 6 is your specific plan name, because there's more than one United Healthcare plan. This is a United Healthcare Choice Plus plan administered by United Healthcare Insurance, but I'm sure United Healthcare has a high choice plan, a premium choice plan, a high plus, a premium plus, you name it, they probably have it. And then on this card, you also have prescription information, which is the box number 7. They use Optum prescriptions, and that is prescription health. So again, not important within audiology, at least at this point in our profession, but that is a prescription. On the back, you see a couple things like, hey, members, if you need us, here's where we are. That's what number 8 is. More importantly, number 9, this is what we want. So when you're asking patients for that provider number, it's often a 1-800 number, I tell them, or a toll-free number. It says, providers, call this number or go onto this website. And so you want to get that information from those patients, again, regardless if you're in or out of network, so you can verify benefits. So that was my sidebar. I hope you find it important. I think it's important that everybody knows. So let's switch gears. We talked about third-party payers, which are the insurance plans. Let's talk about third-party administrators. And a lot of people are going to roll their eyes. A lot of people may not always like what I have to say about this, but your third-party administrators are companies that provide coverage and benefits, a discount program, cost containment, claim process, and or claim managements for another insurance entity. You will often hear these referred to within audiology as TPAs, again, third-party administrators, or 3PAs, again, third-party administrators. We often also call these managed care organizations. So the easiest way I can think to convey this information to you is think of this as the middleman. And I don't mean that in a positive or a negative way. But this is somebody who works with the insurance company to say, we can negotiate all these different things, provide coverage, and give your members benefits. And then we'll go out and actually figure out who can provide that care for us so that the employer doesn't have to do it. So for example, if you work for, well, that's a bad example. If you work for Giant Food Grocery, Giant Food may say, you know what? We don't want to deal with insurance anymore. There's too many claims. There's too many things to negotiate. We don't have time for this. We're going to work with a TPA. We're going to tell them our individuals need to have this, X, Y, and Z benefits. You go figure it out, find a network for us, and then we'll offer it to our patients. And so they are doing a lot of that legwork for the health insurance through their TPA. So really common TPAs, which again, I know Dr. Abel mentioned, there are many, many, many of them. A lot of them are local. They can be specific to unions or workers' comp, but here's kind of the big ones that at least jump into my mind. American Hearing Benefit, Amplifone, which is formerly HearPO, Hearing Care Solutions, which we often hear as HCS, Hear USA, Nations Hearing is getting quite a bit of FaceTime right now, True Hearing, United Hearing Healthcare, which is formerly Epic, and Your Hearing Health Net, or Your Hearing Network, YHN. So let's talk about them a little bit. There are some really great benefits. So there are some great benefits to the audiologist. When you sign up to be a member within the TPA, and again, you're going to go through the exact same process, which I think I show you on the next screen too. Why do you want to join a third-party payer? You go through the exact same process as to why you would want to join a third-party administrator. The nice thing about this is there's absolutely no marketing required. When you work with a TPA, they are going to actively start funneling patients that are interested in services to your office. Those referrals are sent directly to you, and the process is going to be the same no matter what for all those patients that come through this TPA. So it is very, very streamlined. On the kitty corner from that, there's minimal administrative time. Now, it's going to take you a little bit of time to figure out that TPA, just like it would with a third-party payer. If you were to sign up with Aetna tomorrow, it's going to take you some time to figure out all that stuff. But once you get in the process, it's very minimal administrative time. Sometimes it can be a very direct and sometimes even a faster reimbursement than when you're working with a third-party payer. So I know one instance with a third-party payer, I often have to wait more than 90 days to be paid. But when I work with the third-party administrator for that payer, after they switched everything over, I'm getting paid in 45 days. So that's half as much time that I have an outstanding bill. And the reimbursement can be much higher than what you were being paid through that cash pay or that covered system. So a lot of times people think like, oh, TPAs, they're cutting my fees, they're cutting things down. They're not always cutting it. Sometimes they're actually giving you more money than you might have gotten through other third-party payers. Going to the top right, the benefit to the insurance company, they are going to be able to offer more benefits to their employees. And again, when you are choosing a health insurance plan, you yourself, you're probably looking for the most bang for your buck. Maybe you don't always need to see a chiropractor, but if it's a covered service, you like to know it's there, or maybe you've been thinking about it and this put you over the edge to actually go try it. So the more they can offer to their employees at a cost-contained level, the better it could be. They're also going to outsource all these different things so that the insurance company doesn't actually have to do this, or they're doing it in the same manner so that they don't have to try to figure out every different provider's things. Every provider is going to use the same system, the same EHR, the same claim, the same paperwork, the same everything, record keeping, everything like that. And it can be sometimes a cost saver. Obviously, the benefit to the employees is that you might get more and even better benefits because, again, if you have 3,000 people as opposed to 300 people getting this benefit, there's more negotiation power. We know there's a lot of value in numbers, and so you might be able to get better benefits when you're going with a TPA because you've got more people signing up under one name as opposed to 30 different companies offering things each individually. You're going to have a verified network of providers, so you don't have to guess who's in network. You are actually going to go out, and that's one of the nice things about TPAs is sometimes, not sometimes, most of the time or all of the time, they are much more efficient in keeping their list of providers up to date than those third-party payers are. And there's also going to be a guarantee of the quality of care you're going to receive. So oftentimes these TPAs are saying, in order to fit a hearing aid, you must do real ear fitting orientation and quick SIN testing to fit a hearing device. Every single person that signs up for that is signing that contract saying they're going to do that. And so those employees are going to know that they may get a higher level of care than they would if they didn't go through that TPA. So the big question, sorry, is always, do you want to participate? Again, this is going to be very, very similar to what you're going to go through for the third-party payer. The big difference in your market analysis is if you joined a TPA, would you have access to an insurance that you weren't able to join? I mentioned earlier, I've been trying to get a network with one insurance company for the past 4 years, and their network's closed. I just can't get in. They have too many providers. They are not accepting new providers. I call and check once a quarter. It's been closed for 4 years. There's no ifs, ands, or buts. I can't do anything to change their mind. However, I can join a TPA that gives me access to all of those patients that have that insurance. And for a lot of them, I'm getting paid better than I would have been if I had actually joined the third-party payer that insurance directly. So you really need to look at that market when you're trying to decide if you're going to participate. Again, same type of question when you're looking at the employee offerings when it comes to the TPA. And then when it comes to your referrals, because you're not going to be getting these referrals from your physicians or your hospitals, you need to look at how many hours do you need to fill on your schedule. is your schedule half full and you could really benefit from having 20 or 30 patients a month sent to your clinic? Or do you really only need 1 or 2 patients to fill out your entire month? And that might be the difference. And then also, how much cheaper is it for you to join this third-party administrator as opposed to going out and actively getting those patients yourself? So there's a lot of data out there about how much money it costs to actually receive to get a new patient. And what I have found is that, number one, it's different for everybody, but with the TPA, it's often in the area of less than $100. And if you're going to do it yourself, it's often in the area of more than $500 to get a new patient. So again, you need to look at that a little bit in terms of how many patients are coming in. We all talked about affordability in the last one, but you need to look at your reimbursement, which is their version of the fee schedule. And then you also need to look at whether or not there's additional non-covered services. So a lot of TPAs are going to work around testing of the auditory system and hearing aids, but they're not necessarily going to look at the vestibular system. And so might you be able to add some of those non-covered services when you start seeing these patients, if that patient meets that profile and could be helped by that system. And then what benefit, or really, how much are you going to be losing if you don't take that TPA? So I know a couple people in areas that are like, well, I'm not really in favor of this TPA, but because there's so many others in the area that take it, I need to take it in order to stay current with that type of insurance or that certain employer. And so some of the things, you shouldn't sign up because you're afraid of it, but you do have to look at how much would you lose. So for example, there was one insurance company, third-party payer, that switched a couple of years ago, and rather than paying for hearing aids directly, they went to a third-party payer. Well, when audiologists found out about that, some of the audiologists just dropped that insurance and that third-party payer. Well, they lost 40% of their patient base because there were so many patients in their current system that had that insurance. Can you really afford to lose 40% of your business if you don't continue with that TPA? And then the other thing a lot of people don't look at is it a discount plan or a funded plan? And so that discount plan, if it's discounted, you might be able to actually price match rather than going through that TPA. The patient, it's the same cost to the patient, it's whether they're buying it from you or through that TPA. That's not true in every TPA situation, but it's something you need to look at as to whether or not that TPA is a discounted plan. This is also where bundling and unbundling can help you in different areas, which again, I don't want to get ahead of myself because that's a whole nother talk. The other thing you need to look at really importantly when you look at TPAs is the contract to make sure that there's no conflicts. There are a couple TPAs that require you to provide hearing testing for free. So your 92557 is free. And when you're a mandatory Medicare provider, you are charging for that hearing test. And so you can't charge one payer differently from another. And so you need to look at those contracts and figure out if you sign that contract, are you in breach of that other contract? And again, you can't charge one person X and one person Y based upon the insurance that they have. So you need to be very, very careful. And if you don't know, you need to talk to your healthcare attorney to figure that out. And that is money well spent if you're not quite sure, because you don't want to go through that audit type of thing. So this is the part that everybody hates. Why did TPAs come into existence, and why are they around, and why is there so much animosity towards them? And as a ECP or as a student coming into the profession, you're also not going to like what I have to say. And I'm sorry, not everything is fair, but this is what you have for your reality. The TPAs came around because there wasn't really any price transparency in audiology. So again, primarily around hearing aids. We weren't offering, we as an audiology, as a profession, we weren't offering any entry-level products to meet patients' financial needs. So patients were telling us, you know, I need a system that is approximately $3,000 to help my thing. And we were saying, There's no entry level, right? There's mid and high. And so that kind of put us to the second one where everybody was getting premium technology. And so it didn't matter what your problem was, as some audiologists were saying with FDA and FTC in the recent years, it didn't matter if you had a $300 problem or a $3,000 problem, you were going to get a $7,000 solution. And so that's not helpful, especially with a lot of patients who thought that they were going to have some type of benefit. And then there were free offerings that were happening. So there wasn't any value being placed on the services that were provided, the quality of care, or the provider. Everything was going around the price of the hearing aid, which is why so many TPAs are all about hearing aids. And that's really our audiology as a profession's fault. And then we as a profession think we're pretty smart. Sometimes we are, sometimes we aren't. But we were looking for all the possible loopholes to get into. And when we tried to skirt around contracts or find these loopholes, that's when we really started to get in trouble. So when every single person that walked into your clinic needed an upgrade because the insurance would pay, let's say, $1,000 for hearing aids, but every single patient needed a $2,500 hearing aid, the insurances caught on pretty quickly. And those patients were told that they would have a $1,000 benefit, thinking that that was going to be helpful. And in reality, it wasn't, because no matter what, they were having to pay out of pocket much more than they were led to believe. So I'm not saying it's 100% audiology's fault, but I'm saying we had a pretty big factor into it. And so if you don't like what you're hearing, I encourage you to do something to change it. So with that, I'm going to skip through these pretty quickly because you can read through them, but these are two examples of third-party administrators and what they offer in terms of payment and participation. So again, you can read through those on your downtime if you want to do audiology like me, but I want to make sure if there are any questions, I realize I'm already 10 to 15 minutes over, that I'm happy to address them now. And again, as I mentioned earlier, I love my dog. Here's her with her COVID-19 mask on, but you do have my email address as well if you need it. So with that, I'm going to turn it back over to Dr. Babich and Mr. Abernathy, and I'm happy to field any questions.
All right, thank you so much, Dr. Spohr, for that informative presentation. We don't have any questions currently in the queue at this time. However, if any attendees would like to ask questions in the chat, you can take a minute to do so, and Andrew will read them aloud and Dr. Spohr will answer.
Actually got a couple of questions via email. Dr. Spohr, do you have any additional tips for determining the third-party payer for a particular company in your area?
Sure. So yes, yeah. Well, I think I know what that's trying to ask. So first of all, the third-party payers, you need to find their fee schedule, and you don't know what the fee schedule is until you actually know what that third-party payer is. If you're not quite sure what an employer offers, so for example, if you're, I'm from the Midwest, if you are close to a Meijer, which is a grocery store, actually it's much better than that if you knew me, but if you're not sure, my first thought would be just to call them and talk to their HR department and say, what insurances do you offer? That's number one. Sometimes you will get that, sometimes you won't. Number two, you can go and find somebody who works, or if you have a patient, oftentimes that calls in with that information, that's a really good tipping point. Or a lot of times I go to my professional friends. I'm very good friends with my optometrist, with my chiropractor, with my partner's podiatrist, with my family doctor, and I will just simply turn around and say, you know, I've really been interested in this. Do you know what they offer? And so my first recommendation is go directly to the source, but if you're having difficulties, then you might have to be a little more sneaky and do a workaround.
Excellent. Thank you, Dr. Spohr. And another question, if my practice participates with an insurance, which I would prefer not to participate in, Can I opt out, or do I have to be consistent with my employer's participation?
That's a great question. Again, and I alluded to this on one of the slides, when you are a participating provider, it is based on both the provider and the practice. So you could be working at a practice, but be out of network with a said provider. And so it is a possibility to do that. That being said, you have to be very careful that there's the term right now in general is quote unquote surprise billing. It doesn't necessarily mean what we're going to talk about, but it's the same idea. So if a patient comes in and sees you because you are in network with a plan, and then they go see your business partner who is out of network, but they were never told that your partner is out of network and you were in network, and then they have this giant bill, that's a surprise bill, and that can be a problem. So there are a lot of really great reasons as to why one person might be in network with a third-party administrator or a third-party payer, and one person in the same practice is out of network, but you have to make sure it's 100% transparent when you're working with those different patients. But it is very possible. Great question.
Awesome. And one last question. If you intend to relocate, what is the best means of communicating with a third-party payer before you actually relocate?
Yeah, the best thing you'll do, each third-party payer has their own system, but what I have typically found is that you have to send a faxed piece of paper, essentially, on the company letterhead with the provider's name, their office location, and their NPI, and then often the practice's tax ID number or participation number as well, to that insurance to let them know that they are no longer with the company and therefore should be removed from their insurance provider network. So it's just a really simple statement, to whom it may concern at whatever third-party payer. This is to inform you of Dr. So-and-so leaving the practice. You list all the information that's needed. Again, it needs to be on the current company's letterhead, and you fax it into whatever that number is. All of that information is written down in your contract. It's probably also, if you were to just call that provider 800 number or look at their web portal, it will often tell you exactly what needs to be done and the fax number there as well. So if you have 5 extra minutes in your day, which I know we're all busy, but you can just call that toll-free number and get that information as well.
Great. Thank you, Dr. Spoor. Thank you to everyone, and especially thank you to Dr. Spoor and Kaylee. We are out of time for today's session. If you have any additional questions, please send them to me at info@audiologist.org, and we will forward those questions on to Dr. Spoor. If you have friends and colleagues that were unable to attend the webinar today, please let them know that the session has been recorded, and we will send a link out to attendees after the recording is posted. For more information about future SATA practice management webinars and to register, please visit www.audiologist.org/students. Thank you, everyone, and have a great evening.
Good night.
Good night. Thank you.
Thank you.